thank you again for joining us this morning, all of you online. Welcome. You're joining a room full of learners and others within the School of Public Health here in Toronto. You can't see them, or maybe you can see them if I change the camera. So just so you know, I'm not alone and pretending that we're speaking to the empty room. You have the proof. So our learners come from all over Canada, from different organizations, agencies in different roles, as well as from various countries throughout the globe. We started our course today as a module 2 face-to-face, but the course started earlier this year with a virtual module, and its focus is on global health diplomacy. It's an executive course with practical negotiation, diplomacy, global health skills, expertise, and simulation in different fora where global health diplomacy takes place. So as part of that course, we have an open panel, a discussion that we'll have today, and look a little bit further into how countries engage in global health diplomacy, how they develop their plans, how some do better than the others, or some are more active than the others. So we'll have a speaker with us, Dr. Ilona Kickbusch, who will give us further insight into that. And then we'll have some reactions from 2 panelists who I will also introduce. And then we'll have questions from our learners here. And also those of you online, feel free to ask questions. So without further ado, I'm going to introduce Dr. Kickbusch, who currently is wearing multiple hats and is on different panels and committees and advises international organizations and NGOs and private sector on various issues related to global health, handling preparedness, health promotion, you name it. She was founding director and the chair for Global Health and Global Health Center at the Graduate Institute of International and Development Studies in Geneva, Switzerland. She also worked for WHO and Yale University, and is also linked through an honorary professorship with Charité in Berlin. And of course, Charité puts together annual World Health Summits. So without further ado, let's hear from Ilona, and then I will, after that, introduce our 2 panelists as well, and we'll have a discussion there. How about that? Okay.
So thanks very much, Gary, and hello to everyone again in the room and those that have joined virtually. I thought what I would do is give you an overview of this extraordinary year for global health diplomacy that 2023 is. And I'm hoping that gives you a feeling for the numerous negotiation processes that are actually underway right now. I think that is quite unique in global health. I myself cannot think of a year where so many parallel, sometimes interlinked, negotiation processes were happening. And it means that nearly every country is involved in about at least 10 negotiation processes. And you can just imagine what that means for a country, for a member state, usually with rather small departments of international health. You can understand particularly what that means for low and middle income countries, even though I would say for low income countries, because some middle income countries are quite capable of developing very large delegations. I'll come back to that. But that means the burden at the national level to actually be able to respond both politically and professionally, because not only does this mean that you go somewhere and negotiate, it also means that back home, you have to be talking to many, many others, to other ministries, to other stakeholders, etc., to develop what in diplomacy is called a position. Obviously, if you have, for example, a global health strategy that has already been approved and provides the basis for at least certain positions and values, that can help. But again, that will never be sufficient, because at present, global health diplomacy is a speed train. And being able to respond, being able actually also to follow how positions are being shifted around, who is building alliances with whom, is a very special situation, and needs a lot of in-depth analyses if you really want to negotiate in a very successful manner. There are, of course, a number of things that are truly different right now in global health diplomacy. One is what is usually called the multipolar world, but that is absolutely essential to understand. That for a significant amount of time, the power dynamics in global health diplomacy were totally different. And these power dynamics are something that one really needs to understand. They're at the heart of diplomacy, and therefore also of health diplomacy. Now, of course, if you look back, and you look back at power dynamics, you look back at, for example, also who finances the World Health Organization, who gives the most development aid, etc., 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 you can see that in many cases, the regimes, as we call them, the agreements in the international arena, are tailored to the hegemons, to those with the most power. And what we are experiencing right now, that many of the processes, how they happen, and the results that we have in the past, and not the very distant past, they're very much tailored to the ones with the greatest power in this game. And power, of course, also means human resources, people who can negotiate, people who are there. Large representations in Geneva, large representations in New York, etc., etc. You have to basically be everywhere, and you have to be online. And that's another thing that has changed quite significantly. You also have to be online, and the speed with which these negotiations, even though somebody from the outside says, why are they taking so long? The speed compared to earlier times is just absolutely extraordinary. And you are pressured through this, point one. But point two, you are also pressured in your negotiations through the higher public interest in what you are doing, the NGOs pushing for certain agendas, the media interest, particularly now post-pandemic, nearly everything still has a media interest. And so in a way, it's quite contradictory. You know, some people say, oh, global health has fallen off the agenda. Well, okay, you know, global health wasn't discussed at the WEF, for example. Global health wasn't a big part of the Munich Security Conference. But gosh, you know, everybody is out there negotiating global health. And therefore, we also have to be very careful and say, what do we actually mean when we say certain things? So if we say health has fallen off the agenda, it seems that heads of state are not talking about it. But a whole lot of others are. Foreign ministers are talking about it. Health ministers are obviously talking about it. Finance ministers are talking about it. Climate ministers are talking about it. So global health in 2023 is as present as it never was before. And I'm going to describe to you some of the processes. At the same time, of course, there is much more crises diplomacy in relation to global health. Just think of South Sudan. The emergencies are increasing. So also the links between those people who do humanitarian diplomacy and those who do sort of the normal run-of-the-mill, let me call it, health diplomacy, are something that's coming closer together, also because of the financing. Because everywhere you need more money for universal health coverage, for post-pandemic whatever, for the emergencies in Sudan, in Ukraine, and everywhere else. So the issue is, that's why everyone's pulling in the finance ministers and saying, you know, we have to talk to these guys and we need to see more investment. So we have more climate crisis diplomacy, but we obviously have health as part of the climate diplomacy right now. We have COP28 coming up, a very important process. And for the very first time, the WHO is organizing a whole health day at COP28. So health is becoming a focus of climate negotiations. And that means that everyone, starting with the WHO, but people like yourselves who are in the health ministries, suddenly have to be aware of what is happening in all these climate negotiations and have to give your input. Either you are being asked by your environmental colleagues, you know, what do you think about this? What are the data that you have, et cetera, et cetera. You'll be able to describe that. But in other cases, you will be the advocates. You say to your environmental colleagues, hey guys, you're going to negotiate this. Are you aware of X, Y, Z? So many people dying of pollution, this, that, and the other. We see that part of health diplomacy shifting into other arenas. And that, of course, is absolutely central. If you listen to the Director General of the World Health Organization, he says the biggest health threat is climate. So if health people are not where climate is, then, you know, they're not where they should be. So just think, you know, how all these expectations are building up, but it gets even more complicated. And a whole number of things that have become clearer, particularly through the pandemic, they were building up, but we're seeing them come to the fore, is that the diplomacy that states conduct, sometimes global, sometimes regional, sometimes bilateral, around economics, around trade and transport, around supply chains, around technology, around innovation, a lot of them are related to health. Think, you know, about access to intellectual property. Think about your digital health system. Who's building that? The US, Apple, or China? So a whole range of other policy arenas are absolutely central to the ongoing development of health. And our EU colleagues might tell you the story about the negotiations between WHO and the EU. They just signed a memorandum of understanding of working together in a very important area about sharing health data in periods of crises, etc. So, you know, what I'm trying to bring across is not only is the power in health diplomacy changing, the issues being negotiated as part of global health diplomacy are totally different. And that's not only because the issues are different, that's also because the power relations are changing. And one of the really key things is that you have a group of probably about 6 so-called middle powers that are starting to define the agenda. And I mean, I could now say, name them, but you probably all could. It's Brazil, it's India, it's Indonesia, it's Saudi Arabia, it's South Africa, and it's Turkey. those middle powers are pushing the agenda. These middle powers are the fence sitters between China here and the United States there. And Europe is sort of, jumping around, where should we be? You have underlying that a conflict between democracies here and autocracies there. So, everyone was saying we don't need the G7 anymore. We've got the G20. They will define the agendas. Well, the G7 is redefining itself as the group of democracies that's trying to hold up certain values in the course of this changing world. So you have why, because the division of power is not that clear anymore. We're in this in-between space. You sort of have three reasons why these countries have such power. They have much more agency. They have developed. They have very excellent professionals. I was at the G20 meeting in Goa. I mean, that was mind-blowing to meet the colleagues from India working on the digital transformation, working on climate, etc. Absolutely extraordinary. They benefit from regionalization because we have a de-globalization period now, and everyone wants to be the regional center. Very important role that South Africa is playing, for example, here, also for the African continent. And they can leverage the tensions between the US and China. And you saw at this year's World Health Assembly, you saw this very, very clearly. I just want to share the results with you. Ukraine and the European Union, because geopolitics is back in WHO, put forward a resolution on Ukraine and mainly the destruction of health facilities through Russia, etc. It was accepted after quite some discussion. It was accepted with an 84 and 9 against. 88 countries abstained or were not present. All African countries were not present or abstained. And then, take the 6 I mentioned earlier. So that tells you the complexity of negotiations. And it shows you that as geopolitics moves back into the WHO, what that means for nearly every other health negotiation. And we've seen that clearly within the context of the issues that were being discussed. So which are these meetings that are coming together in this period? Obviously, we've just had the World Health Assembly with a very, very tight agenda, with an agenda, as I say, that also got embroiled in geopolitics, in an agenda that on the one hand expressed, everyone says crises of multilateralism, but after all, the member states agreed to an increased budget of the World Health Organization, which was a historic breakthrough. Definitely not enough, but it was a signal. This is an organization we belong to, an organization that we want to continue to work in, and an organization that we trust. Now, next to, of course, this negotiation at the World Health Assembly and everything that comes out of it, we have the 2 other WHO processes that you are partly negotiating in this course as well. Let me just call it the Pandemic Accord, the Pandemic Treaty, and the International Health Regulations. In one area you have, and here when you look at it, you have different types of processes. For the International Health Regulations, which exist, You have a working group on amendments. For the pandemic accord, you have an international negotiation body. So, you know, you have a different process. And one of the important things to keep in mind is that the minute you start to embark on something like this, like a treaty or something, you can be sure that, you know, the first period will be spent for hours, days, weeks sometimes, to actually agree on the process. So first you negotiate the process, and then you negotiate what you're actually going to do, what you actually think the content is. And as you've learned in your working groups, you have different types of drafts in terms of, you know, an initial collection, then you have a bureau set of options, and then at some stage you get a first treaty draft. Now, of course, wanting to do this in 2 years is something that a lot of people are starting to question. I personally think if one had clearly started with a framework convention, one could have done it. And as far as I know, that was the model that the European Union had in mind, a framework convention on pandemic preparedness and response, and then a whole series of COPs dealing with the complicated issues. What we have now is that we have all the complicated issues within the negotiations themselves, and we'll see where that leads us and what a whole set of problems can be that emerge from that. We are also seeing, because of this new world, and Gary, you give me a signal when I'm sort of going over time. What we're seeing is that the power balance, not only in relation to those 6 core countries, but in general between, let me be simplistic, the global north and the global south is shifting. Because first of all, the global south, with all the experiences it had during the pandemic, doesn't trust the global north one single bit anymore. And that's very difficult, to go into negotiations without trust. That is really the most difficult thing. You can go into a negotiation with different interests, with different positions, with different goals, with different ideologies, with all kinds of stuff. That's why you're doing negotiations. That's why you're doing diplomacy. And I've just been reading the book by Catherine Ashton, who was the first foreign representatives of the European Union, and she describes how she felt sitting in the room with Putin. But you know, that's diplomacy. That's why you're there. But in this case, it's not just you have different, of course you have different interests and goals, but if you don't have trust anymore, then you're really in deep trouble. And this is one of the things that negotiators are experiencing now. And based on the experiences with the pandemic, this is what you said you would do, this is what you promised us, this is what you finally did. And of course, vaccine nationalism always comes up first. And this is intermingled with a process that I've indicated is going on anyhow, the process of regionalization, the process of wanting to be in control of your own development, also in the sense of scientific development, in terms of innovation, in terms of the supply chains and all of that. And, you know, there's all this new talk about either sovereignty, you know, data sovereignty, health sovereignty, terms that are really important also for middle-income countries and also for the countries involved in the negotiations. So what you get in all these health negotiations, particularly from the Global South and from the NGOs, are 5 issues that they always want to see. transparency, inclusiveness, equity, accountability, fairness. So whatever is brought into the global health debate right now is being judged on those 5 principles, on those 5 criteria: transparency, inclusiveness, equity, accountability, fairness. And, you know, that's where partly this whole negotiation, and particularly about the present draft of the accord, where, you know, whole chapters have fallen out and disappeared. You know, where's human rights gone to? Excuse me, you know, where's equity? Where's UHC? You know, we'll see what happens there. But the other thing that you have to keep in mind, while it is great that, you know, there's these 10 negotiations going on at the same time, what that allows you, if you're very astute, and that's what many countries do if they have the resources, that is what we call regime shifting or forum shifting. There's various terms for it. That is what you want. You test it out in different places. And you try to move the key part of the negotiation to the forum where you have the most power. So some very powerful countries prefer to move the discussions from the WHO in Geneva to New York. Because, first of all, foreign policy calls the shots there, point 1. And point 2, certain strong countries have more say in New York. And we have that whole discussion around the proposal of a Global Health Threats Council right now, which, you know, some people want to keep in Geneva, but since it probably won't fly in Geneva because it takes power away from WHO, there's this push, let's take it to New York, because then there is a higher probability with the pandemic summit that it will be approved. So I said a lot of time at the World Health Assembly, the Executive Board. Remember also there's going to be 3 regional elections in the WHO within the next year. So that will also politicize the whole negotiation arena much, much more. And that is something we need to keep in mind, because countries will be positioning their candidates according to their interests, and certain countries won't accept certain candidates. So there was a suggestion by the European Office that's approved by the European member states that Ukraine become part of the Executive Board. Russia said no. So there had to be a voting whether Ukraine could be on the Executive Board. So the next thing that happens, up pops the United States and says, we don't want North Korea on the Executive Board either. Now, it has been eons since WHO has had discussions like this. So quite aside from the fact that, you know, geopolitics, it's always there around Palestine and Taiwan, always. But, you know, that's nearly a ritual now, I would say. But a ritual, particularly in relation to Taiwan, that's going up like this, given China's present position. So just to indicate then some of these other processes, I mentioned Goa, G20. India has really put a dynamics into the health discussion that's quite extraordinary. There is a political debate that the African Union become a member of the G20. You'll be aware of that. And also the last years, more and more African countries have been invited to participate in the G20. We have a group of 4 of these middle powers running the G20 over 4 years. Indonesia, India, Brazil, South Africa. Their agenda, they're all in the BRICS. They're all still talking with Russia. They are clearly out to change the agenda. And it is fascinating to watch. And you can start to see very, very strong commitments there. The G20 India is very keen in its cooperation with the WHO. It's trying to push also a new digital agenda for the World Health Organization, a really important agenda, but most of all, it has taken on one of the most contentious issues within the discussion at the WHO, and that's the medical countermeasures platform. How are countries going to work together in order to ensure that there's medicines, diagnostics, and vaccines, both in terms of their development, but also in terms of crisis situations, because many of you will be aware there is a mechanism called Act A, but that mechanism has been evaluated, partly heavily criticized, also for leaning too much towards the global north. And so India sees its role also together with the developing countries to actually change that agenda and take it forward. If you look at this issue of medical countermeasures, it also indicates to you how some of the processes run. I mean, there's all the emergency diplomacy processes that we had during the pandemic. But now, for example, what happens is a group of countries comes together, in this case, it was South Africa and Norway, to host a technical meeting to say, how do we take Act A further? That technical meeting was then transformed into something that produces a suggestion for an equitable and sustainable medical countermeasures platform. That was picked up by the G20, that's being negotiated in the context of WHO. So you see how these various processes sort of support each other. You have the formal process and the formal process. You have informal processes, friends of the chair, friends of UHC, etc. You have informal processes like track 2 diplomacy, where citizens go and try, and clarify the field. Science diplomacy often plays that role. But we're seeing that science diplomacy, since science has become such a key issue of power, science diplomacy is becoming much more difficult. We used to use science diplomacy to still work together, Chinese universities and German universities and Indian universities, no more. We don't trust you with our science. And that's very scary for health. How do we develop a vaccine together if we don't trust each other, if we cannot ensure the cooperation between scientists? And this is a real challenge for the chief scientist of the WHO. So watch the G20 and its 3 health priorities that it set. The Brazilians, of course, are already in the process of developing that. At the same time, while the G20 is going on, the G7 is moving forward, headed by Japan, very important constellation in the Indo-Pacific region also. That region is becoming ever more important, and focus on universal health coverage. But whereas G20, India, focus WHO, G7, Japan, focus New York. Now, there is one reason for Focus New York, because of the various UN meetings that are going on, that are being negotiated, high-level meetings. But also, health is very much, global health, a priority of the Japanese Foreign Ministry. And as I said, in New York, it's the Foreign Ministry that calls the shots. Actually, the person in charge took my global health diplomacy course. I don't know what I should think about that. Looking very quickly at New York, you have at least 5 processes going on there that are relevant for health. You have a high-level meeting on universal health coverage. you have a high-level meeting on tuberculosis. You have a so-called pandemic summit. That pandemic summit was called when people thought, nothing else is going to happen. We have to get something going. Now, I think most people wish we wouldn't have a pandemic summit, but nobody dares to cancel it, except those who want to use the pandemic summit to disempower WHO. Those are, of course, pushing for the pandemic summit. But we mustn't forget that there's two other summits that have a very high health component, and that's the Summit of the Future that the UN Secretary General is working on, and the SDG Summit that has an SDG 3 assessment. So all this means, and those of you that are sitting in international departments will know how this stuff is just, flooding in. Comment here, comment there, position here, position there. And you can't just do a copy paste in most cases. And this is really, really very, very challenging. And aside from that, there's other things. There's just been a very important SDG 3 assessment in the context of UNCTAD just a week or two ago, for example. So, how do you keep up? How do you, Twitter helps, but otherwise it's really quite difficult. And then, as I've already said, you have the other global negotiations. You have COP28, climate and health. You have the plastic treaty. Absolutely important treaty. If you've been at the World Health Assembly and heard what plastic means for health, microplastics, the islands, South Pacific, Caribbean, etc., are saying, guys, do something. It's not only in the fish, it's in us. And therefore, starting the plastic treaty now, we had the first step, the Treaty on Oceans, I think it was called, 10 years of negotiations. Now, this is the next step, the plastic treaty, again, with a very high health component. And that is something we health people also have to be very on top of. To give you an example, a couple of years ago, the health people were not very much on top of the negotiations of the Treaty on Biodiversity. We're paying the price now because the agreements on biodiversity didn't think that there was such a thing as a virus. And so you can see that if you're not on top of these things, you can actually miss out on a really important part of what defines a global health agenda, defines agreements, defines cooperation, and other things. Last points, I guess, is there are areas that I find health negotiators always forget that they exist. For example, that drug policies are negotiated in Vienna, illicit drugs. So totally different people go to Vienna and discuss drug policy. One of the reasons so many countries have such restrictive drug policies are because of the recommendations that come out of Vienna. Now, initially, the big problem there was that the Americans had very restrictive drug policies. And, they made clear that nobody else could have more lenient ones. That started to change under Obama, et cetera, et cetera. But the interesting thing was that then the Russians stepped in, and the Russians became the voice, the very strong voice for restrictive drug policies. Now, suddenly in Vienna, you have an opening because the Russians are losing their power. And you can see that for the first time, an agreement came out, a resolution out of Vienna, actually proposing an opening up of this incredibly restrictive drug policies that are coming out of Vienna. But my own feeling is many people in global health that I talk to say, Vienna, drug policies? What's that got to do with us? It's again, a totally different group of people. And then we haven't even started talking about the World Bank reforms and the impact on global health and the increasing work of the World Bank in health, not only classical health, global health, diseases, pandemics, etc. But for example, next couple of months, a big report on digital health is coming out of the World Bank. And of course, the starting point of an economic organization will always be a different one than the starting point from a health organization. And so at the same time, you have to sort of be aware, because some of the countries, particularly the United States, is incredibly keen to push certain health responsibilities into its closer neighborhood, let me say. So, if the pandemic fund is with the World Bank, it's in Washington. If the Global Health Threats Council is with the UN, it's in New York. So while even on other issues, some, particularly developing countries think, oh, the West, they always want the same. There's an incredible fight, partly, particularly between the European Union and the United States on a whole range of health issues, particularly if they're structural, because the European Union is fully also in its new global health strategy behind the WHO, whereas the United States is not totally convinced. Let me put it this way, even though under the Biden administration, it has become much better. So, so to end, I think it's really important to see how the power shift is really happening in global health, how this regime shifting, because so many negotiations are going on, is exploited in a whole number of ways. That, of course, in parallel, while you're doing this global stuff, there's all these regional negotiations going on. The African Union, for example, has changed the responsibility, has given the African CDC more power, for example. So the African CDC has new diplomacy challenges with the African member states, for example, and with the African regional office of the WHO. So you have all these movements that are also going on in parallel, and that, of course, will reflect on the other things. So I've mentioned to you some of the powerful middle powers. We are in a middle power country, Canada. And it's quite important then also to see in this complex environment, how can a country like Canada, with clear positions on certain issues, sexual and reproductive health and rights that are sort of being pushed out of the window more and more, indigenous health, the World Health Organization for the first time adopted a resolution on indigenous health, incredibly important also for Canada. So how does Canada position itself with this neighbor next door, with certain leanings towards the European Union and some of the values? So it's really a challenging time for Canada to say, this is where we stand, this is where we can perhaps free ride, this is where we've got to be careful. This is where, as a country that has a very good record in development, we are trusted in a whole range of developing countries. How can we play a role, perhaps, of a broker in a whole range of situations? Because obviously, But even Canada didn't look too good with the vaccines it ordered and was sort of in competition with the European Union there, you know, who can hoard most perhaps. So even here, trust has been lost. And so I would just urge you as you embark and continue in global health diplomacy to watch very carefully what's happening in geopolitics. It's going to influence global health negotiations to their very core. It provides opportunities, it provides a lot of threats. And of course, there's a whole range. I haven't even spoken about, you know, what's happening in the NGO community, the decolonization movements and all of that, all things that are moving things forward. And at the very same time, health being really threatened to the core. The NCD resolution of WHO highlighted this through the commercial determinants of health and the big difficulty of actually responding to this enormous economic power for ill health that is out there. So a great area to be in right now, global health diplomacy, and a great opportunity for Canada to define its role and take global health a step forward. Thank you.
Okay, great. Thanks, Ilona, for that great overview, and particularly with specific examples from countries and where different emerging powers coming in. That's very helpful and very important. So let's invite two panelists again to reflect a little bit, but also bring their own perspectives. So I have Dr. Joel Lexchin, who is Professor Emeritus at the York University at the Faculty of Health, where he taught pharmaceutical policy. And he also is Associate Professor at the Department of Family and Community Medicine here at U of T. And he obviously had a long career and provided advice to Ontario government, to federal government, governments of New Zealand and Australia, as well as WHO. And then we have Mark Brender, who is the National Director of the Partners in Health in Canada. So he can tell you more about that, obviously, how that works. And he actually led the establishment of that in 2011 to strengthen the work of Partners in Health globally and link that to the Canadian movement of health for human rights. So both of them will bring their perspectives and hopefully also add how Canada engages, or how academics or NGOs engage in the diplomacy that Canada promotes globally. So maybe we'll start with Joel, followed by Mark. So I'll invite you here.
Okay, so I have 10 minutes to cover a huge area, which I'm not going to be able to do. I think Ilona gave you a perspective on the depth of the issues that are involved, and I only know about a few of those. So I'm going to stick largely to what I know. And one of them, or the main one, is drugs. Not the kind you smoke, but the kind that you take as pills, injections, whatever. I've been working in this area for about 40 years now. So I want to start to talk about Canada and Canada's role both domestically and internationally when it came to the pandemic. Well, the pandemic is still ongoing. So there are a couple of areas where Canada failed miserably. The first one is around the contracts that it signed with the various companies. It actually signed 7 contracts, The contracts were signed based on the advice from the National Vaccine Task Force, which was established early on in the pandemic around May or June of 2020. 13 people were on that task force. 12 of them had conflicts of interest with pharmaceutical companies, which the federal government knew about and decided to ignore. So did those conflicts of interest have any effect on the contracts that were signed? Well, first of all, there were no minutes of any of the meetings that the task force had. And secondly, most of the clauses in the contracts have been kept secret. So we have no idea. The second area that I want to talk about is international and what Canada did or didn't do in terms of the pandemic. So Canada, to its credit, gave a lot of money for vaccine research. I believe over $1 billion for different kinds of research. But none of the contracts that it signed with researchers, none of the money that it gave away had any clauses around who owned the intellectual property rights, what kind of prices were going to be charged for the products, where were the products going to be sold. All of that was ignored by the Canadian government. Ilona hinted briefly about vaccine nationalism when it came to what Canada did. Canada was supposed to give 200 million doses by the end of 2020. It still hasn't reached that target, at least as of a month and a half ago. And a lot of what it gave was not physical doses. It was money to buy doses. But when you have no doses to buy, money doesn't mean anything. And Canada, the last time I calculated, signed contracts for a potential 375 million doses of vaccine. So if we had actually got all those, we would all look like pincushions, because we would have been vaccinated 10 times. So we didn't give money, we didn't give physical doses. We delayed giving making donations. There were all sorts of excuses around why there were no physical donations early on. And the final area that I want to talk about, and this goes to a wider area, is the WTO waiver, or the TRIPS waiver. This was advanced early on, I think in June of 2020, by India and South Africa. And the idea was that there would be a time-limited waiver, not just on patents, though, but on all forms of intellectual property. So that includes scientific know-how, technical know-how. It's anything that was required to make either diagnostics or treatments or vaccines to deal with the pandemic. And Canada's position drew on its history. And Canada, since 1999, when the first major debate around access versus intellectual property occurred, and this was around South Africa and South Africa's attempt to get generic products for HIV/AIDS. Since then, there have been 6 or 7 other episodes where there was a decision to be made: should Canada support intellectual property or should it support access? So this was the Doha Declaration, the treaty around non-communicable diseases, or actually it wasn't a treaty, it was a high-level meeting. And in each case, we came down on the side of protecting intellectual property. Canada never took a firm position that access was more important. And we did the same thing when it came to the TRIPS waiver. If you read the comments from Mary Ng, who was at that point the international trade minister, or other Canadian officials, it was very wishy-washy. Well, what's the evidence that IP is delaying vaccine access? And are there other issues that might be involved? And on and on and on. And in the end, Canada, when there was a final agreement, very poor agreement, by the way, only restricted to vaccines, only related to patents, and only for a 5-year period, doesn't cover anything else. When that was finally announced, did Canada say anything about that? And the answer is no. So we maintained our tradition of supporting, even passively, IP versus access. Okay, so that's enough about Canada. How much time do I have left to rant? 1 minute. All right. So let me just say that there's another area that Ilona didn't talk about that concerns me quite a bit. And that's the role, not just of corporations, because corporations have a major influence on healthcare, but also the role of philanthrocapitalism, i.e. Bill Gates, but not just Bill Gates. There are other foundations, but Bill Gates has been able to subsume a lot of the air around global health because of its money. It doesn't give all the money that there is, but it gives enough so that it can drive the debate, drive the way that issues are being talked about. Bill Gates, Bill and Melinda Gates Foundation is accountable to, I think, 4 people. Bill, Melinda, Bill Sr. is now dead. I don't know who replaced him, but those are the people that it's accountable to. It's not accountable to anybody else. It's got huge amounts of money, and it's got a specific ideology which came clear during the pandemic, which is technical fixes. And that's fine. You know, we're all grateful for the vaccine that was developed, but health is more than technical fixes. And with Bill Gates's fixation on technical fixes and his fixation on the protection of intellectual property, we need to be wary of that. We need to be wary of this drive to push healthcare out of the WHO and into these other organizations which do good work. I'm thinking of things like Gavi, but again, Gavi and other things are public-private partnerships. And who is the private sector in these responsible to? And the answer is nobody. WHO has lots of flaws. But at least theoretically, it's one country, one vote, which is better than Bill Gates or any of the other corporations that are involved in these triple Ps. So I'll leave it there and be happy to take questions later on.
Thank you, Ilona. That was fantastic, and thank you, Joel. It certainly. So I'll give a very short background. I'm again with Partners in Health Canada, so we're a global health NGO based here, but work with a global Partners in Health family. It was founded really in Boston and in Haiti in the 1980s. and have worked to strengthen health systems really in mostly low-income settings around the world since then. And so, you know, any comments here are really in the context of someone who has learned and benefits from the expertise of our colleagues at what we call care delivery sites in 5 countries in Africa, in Malawi, Liberia, Lesotho, Sierra Leone, Rwanda, and certainly in Haiti, where the organization was born. And certainly don't deign to speak for any of my colleagues or the governments that they work in partnership with to support. So we work to support public sector health systems in countries where we work and communities where we work, and prove that it's possible to deliver high quality care anywhere, as opposed to settling for what has been over the years in global health policy, some basic package of services or standards that primarily the West has deemed suitable for low-income countries based on a premise of let's allocate a certain amount of money for health in poor areas, and then what can we do with this limited pot of money? And so we push back against that in a whole bunch of ways. Picking up on what Ilona said about trust, and I think that's so true, is that during the pandemic certainly exposed the dichotomies in terms of you know, what is seen appropriate for rich world, what is seen appropriate for poor world, and how the rhetoric of solidarity that we heard coming out of many countries, Canada certainly at the fore, the European Union, the US, all included, fails to match what happened. I think that trust has been something that came to the fore during the pandemic, but has existed for a long time, the lack of trust. In places where we work, certainly in a place like Haiti, certainly in many parts of Africa, because of the historical context that contributed to the very weak health systems that we see, right? And so those are structural violence of all kinds, structural adjustment programs, the work of the World Bank and the IMF over many, many years, impacts and legacies of colonialism. So to speak very quickly to the context in which countries in these areas of the world come to the table, and why some of the regionalism that Ilona spoke about, I think is really crystallizing for very, very good reason around fostering the need for continental independence, certainly for Africa, and in other places, is because when you go and you see what ministries of health, what their budget is to deliver health services, and in places where we work, it might be $20 or $30 or $40 per capita, right? So that's what the Ministry of Health budget is. And the Ministry of Health in places like Malawi or Sierra Leone or Liberia might be 20 or 25% of the total health budget of the country, and the rest comes in from outside. So the ministries of health are impoverished for all these reasons. You know, illicit financial flows drains more from the global south than all the aid that goes in. And so that's a whole nother discussion. But the context when you have such scarce budgets of ministries of health, and then you have a pandemic instrument and a pandemic preparedness agenda that is really built on health security, right? It's being driven by the West, and it's being driven on what is the public health surveillance capacity in countries where we work to detect disease, to raise alarms, but it's not built around treatment, right? It's not built around healthcare, because we see what the budgets are. And so what is the conversation like in many of these low-income countries where there's a health security agenda that is being built after the pandemic, right, to ensure protection, that this doesn't happen again without investments in health system strengthening. And I think if you spoke to most ministers of health in places where we work and you say, what is your priority? It's the ability to provide health services for our citizens, right? And the securitization agenda, yes, I think certainly in public, everybody is going to be very supportive, because who's against preventing pandemics and who's against, you know, public health surveillance? But the extent of the lack of healthcare that is available for all these historical reasons and for current structural reasons that cause, in many places where we work, volunteers, volunteer nurses, volunteer lab technicians. I was in Sierra Leone, Liberia about a month ago, and to go tour a TB hospital, the best in the country, and to know that the gene expert machine, right, is only able to run 24/7 based on 2 shifts of volunteer lab techs who are not getting paid because the Ministry of Health has no resources to pay them, in the hope that they can get a job a year and a half from now by proving that they can show up to volunteer when they can, when they're not raising other money. In a place like Malawi, when we're training nurses and they can't be hired because of IMF regulations about not being able to increase the capacity of the public sector, right? Because you can't increase public sector employees, the public sector salary burden. And if you do in health, then it has to go down in education, right? And so the context in which all the discussions that Ilona mentioned, and the context in which the decisions during the pandemic were made and how they're reflected and viewed by countries where we work, I think is certainly something that is driving the regionalization and the push for independence and the push to reform at all these levels, including IMF and World Bank, and the notion of further independence of Africa CDC and WHO in Africa. I think all these things are very interrelated, but look forward to the conversation.
So the people online can see you. And of course, we'll just have a few questions from learners first. So perhaps I'll look at the room here. Okay, we have at least one just to get a sense. Okay. All right. Yes, I'm again going to prove that they're real people in the room, and oh. Okay. Are you not there? Okay, try. Okay, please. You have a question quickly.
Yeah.
Yes, please.
Yeah, thank you very much, everyone. That was really enlightening. Taking it from where Mark stopped about if developing countries were asked, what do they want to do? It would be how to provide services. And Ilona stressed so much on the power dynamics. So going into these negotiations of diplomacy, and having worked with at least 2 countries, their government closely on health, I really question the ability for them to set up their positions for negotiation. I question their ability to define their roles in those negotiations. So they're not even going to be part of the middle power that you talked about. They're going to be just there to receive whatever it comes, and we see it play out in those countries. Verticalization. For instance, where I work, so much problem, but because there's so much money for HIV/AIDS, it's only HIV that we are working on. So my question would be, what are the opportunities to provide capacity for this kind of negotiation to developing countries so that they're able to prepare to get the best out of the process, one. And you talked about those 5 principles: fairness, equity, transparency, accountability, and the rest. There's a benchmark for negotiation that I've had in my head for a long time, 50-50. Reaching a consensus and going, now we're happy. But what will you say is success in diplomatic negotiation? Because what we see as success now is not success for low-income setting countries. So what will you define as the optimal success, even if it's not in practice, in theory, what is success? So that those of us working on the field can, work towards that. Thank you.
Okay. Just want to get a sense in the room. Who else has a kind of, okay. Anything that you just heard that you had a similar question to? No. Okay. So maybe quickly, whoever wants to go.
Well, just one thing. In diplomacy, you rarely get optimal success. I think that's one thing. You go into a negotiation to get as much as possible, obviously. But I think there's rarely a negotiation where you get everything you want. So you have to be clear about your red lines. You've got to be clear about what you might be willing to concede. And you've got to be clear about what's the minimum that you want. And I would say a global health negotiation is always successful if it takes us one step further towards equity in health, if it takes us one step further along those 5 or 6, whatever other principles you might want to add. In some cases, it's a human rights dimension. You know, I think those principles have to be clear, but it's really, I mean, global health is about health for all. And if a negotiation doesn't improve the equity, then it's basically failed. That would be my answer. The capacity for working for particularly the African countries, I mean, we see that slowly they are starting to work together more to develop their positions. It's difficult because, of course, also not all African countries agree. And we know from the European Union, even EU positions aren't really supported by all countries, and then they come in again. But I think it would be a fantastic opportunity for the African CDC with the new global order, you know, new public health order for Africa that they are developing, that this, you know, understanding of the international health diplomacy arena and the way that African countries put forward their positions is really, really critical. Because there's also, you know, we've heard all about the stuff that, you know, all these global north countries and people and philanthropists and whatever are doing. But just because China says it's a developing country, it's not, you know, doing everything in support of Africa either. So I think also being able to analyze, you know, where one wants to take support, where one wants, you know, what creates dependency, and as one moves from one dependency, that one doesn't, you know, fall into the next big trap. And I think those are all issues that there's fantastic intellectuals in Africa. I keep reading their books, you know, just absolutely great. And if there was an institution that started to create that, that knowledge, that approach, those skills also, I think that would be fantastic and make a real difference in New York and in Geneva, definitely, but also regional negotiations and the kind of bilateral stuff, you know, in the Global Fund when they come with their ideas, or Gavi or others, you know, to be really self-sufficient and say, these are our conditionalities and not yours.
Okay, and I thought capacity-wise, this course is the capacity answer to everything, isn't it? No, but it's role. Okay, let's go to one more from the audience. Or who wants to go? Sue, who wants to go? There's not a competition.
Thank you. Really quick, a lot of things to say, and thank you very much for the presentation. I will focus on 2 points. The first one is science diplomacy. I will insist in this topic because health is really a very highly technical issue, and I was wondering what for you would be the role of WHO in terms of risk assessments, and let other international organizations as WTO to really lead in terms of risk management, for example, medical countermeasures platforms. So really divide where all these arenas and policy arenas that are implementing, and if there will be a relation here in terms of who does the science and who does the operational process. The last one is for all. I think with all this highly political global health agenda really going on and all the negotiation process right now, don't you feel that there is potentially a risk for even more fragmented role in global health? Because with all these negotiation process happening in New York, in Geneva, and in other forums in different organizations. I have the feeling that in the end of the day might have a really fragmented response to the global health issues pressing nowadays. One last word in terms of negotiation processes, because everything is towards health protection, communicable disease, most of it. And still there is a huge gap, and I know that we talk about a huge gap in terms of the main risk factors for NCDs, and that is the highly burden of disease nowadays everywhere in the world. So commercial determinants of health, it's something that we still need to talk about a lot. Thanks.
Okay, so who wants to go next? Joe.
A lot of issues. I'm not going to try and tackle them all. Your first point about science, and I think that we have to recognize that science is also very political, that what gets researched and what doesn't get researched. So which questions are important and which ones aren't. And that's determined by where's the money. You know, there was a bank robber in the US in the mid-30s. When he was finally caught, the story goes that some reporter came up to him and said, "Willie, why do you rob banks?" And Willie said, "Because that's where the money is." So if you're looking at doing science, where's the money to do science? Where's it coming from? And it's largely not coming from the global south. There's a little bit, but it's coming from the global north. And that money is controlled by political agendas. And the interpretation of science is also governed by ideology. So we were looking at issues, is the COVID, the virus transmitted by aerosol droplets, or is it airborne? Because those had very different determinants in terms of what we did, how, you know, social spacing, things like that. Should we be worried about filtering the air? And for a long time, the dominant view was that it was aerosol. So large droplets could only travel 6 feet, 2 meters. And then, so you didn't have to worry if you were beyond that. But it turned out that in fact, it was airborne. So that had much different implications. So science is not just doing the experiments. It's also which experiments get done and how are the results of those experiments being used. I'll stop there.
Yeah.
Just 2 short issues. Fragmentation, yes, is the short answer. The second answer is that each of these processes frequently wants an outcome. And the press, the NGOs, the international community wants an outcome. You know, the G20, G7 were originally actually created as debate clubs, and they were very useful as debate clubs. Now one wants outcomes. What's an outcome? A program, an institution, a fund, whatever. And so that's one of the reasons we're seeing this inflation of, you know, all kinds of new initiatives, new funds, new this, new that, because also all the commentators on these processes only accept something. Oh, they've created a fund, you know, oh, they've given 30 billion, which by the time, you know, you've forgotten and it never really came. You indicated that as well. So I think, yes, the fear of fragmentation or the reality of fragmentation continues. In terms of where the money is, there's the one thing, you know, in terms of science, obviously, WHO needs to do much more in relation to science. There was a period where WHO hardly did anything. And I think now with the second chief scientist, we're going to see a significant movement there, and the platform for countermeasures is one of the areas where a lot of these things are being discussed. But I think it is about, quite new mechanisms and tools and standards and quality issues that will need to come forward. And finally, NCDs, that's really where the money is. The money is in NCDs. Whether you're producing drugs, the money is in NCDs, or whether you are producing consumer goods. And the consumer goods are obviously alcohol, fast foods, sugar drinks, you name it. It's an enormous ill health industry. And it's not about corporations, it's about investors, because that's where the profit is. And we haven't done enough of that in global health, because obviously, if you're a pension fund in Australia, you need to have profits with your investments in order to pay out the pensions, whereas the profit in consumer goods. So you go off and kill people in one part of the world to pay the pensions of the people in the other part of the world. Now that's a really interesting element of inequality, and we haven't tackled that yet.
Okay, thank you for that. Let's see, Sue, you go next, and then Jonathan. For the panel, we have a question from the people online. How can Canada build trust, considering there is mistrust from South, and what can Canada actually realistically do to build that trust? I don't know who wants to do that, but definitely not Ilona. So let's see.
Never tell Canada what to do.
All right. So let's, Sue, please.
Great, thank you very much to all of you. A question for Ilona, just based on a comment you made. So you maybe cast some doubt on the current process of the pandemic treaty and achievability of that within a couple of years, and said that maybe an ideal way to go would have been through a framework convention and then some COPs. So I'm just, as I'm learning, I'm just understanding the processes. Why would that be a preferential way to go through framework convention? What are the benefits of that?
Well, the long answer is, or the short answer, we've actually tried to explain that in a couple of articles if you really want to dig in. So I'm just saying that because of that. But the thing is, a framework convention is exactly what it says. It's a framework. And it sets the framework for the direction you want to go in. It sets certain principles. It does include certain agreements. And, the example per se is, of course, and we'll be talking about that, the Framework Convention on Tobacco Control, which was also negotiated quite rapidly because, so much work had been done before. So what you do then, and that's, one of the problems that people always raise about the treaty, is that it's not multi-sectoral enough, and how can WHO do a treaty when it's not responsible for, I don't know, 50 other ministries and actors and whatever. Now the Framework Convention basically then, if it's adopted, gives you a treaty secretariat, a convention secretariat, which separate, which we have for tobacco. It was actually celebrated at this year's World Health Assembly as well. And then what you organize are so-called conferences of the parties that take up areas, that have either already been identified as a priority in the Framework Convention, or, come up because the world changes. So the really complex negotiation of smuggling tobacco, for example, was taken up in a COP for, I think, 8 years or something. Well, but it brought customs officials and everyone and sundry that had something to do with this agenda together around a table, which of course you can't do in a treaty negotiation. So it's a greater level of pragmatism. And Charles Michel, the president of the European Council that had initially suggested a treaty, you know, being from the European Union, what does he think of? Of course, a treaty, because, you know, that's what the European Union does, laws. But he said, you know, please don't do a Christmas tree. And of course, in global health, everyone will know this, you know, the minute you come up with any kind of instrument, everybody else comes in and links your treaty with every other issue. And of course, this is what happened in this negotiation. So suddenly this pandemic treaty was there to solve all equity issues, to solve debt issues, to solve IP issues, to solve UHC issues. The list goes on. And that, of course, is totally unrealistic. So then they try to clean up, you know, this 30-page draft or something. And of course, while doing that, they did lose some, you know, really important things, like, you know, a really important introduction on principles, for example. But that's basically the thing. And that's what they'll have to really think seriously about when they meet in June, you know, in a week or so, to say, you know, which is the instrument we really want, and what is realistic, because it can't fail on the one hand, and on the other hand, it can't be, and this is definitely, I think, also WHO position, a pure health security instrument. I mean, it does have to have a universal health coverage dimension in it. I mean, Director General Mike Ryan, everyone says all of the time, the pandemic begins and ends in the community. Well, if that's the case, you know, what do we need in the community? And this is, you know, what our two speakers here have so clearly said. And even Bill Gates talks about primary healthcare now. I don't know what it's worth, but I remember having a major fight with him about 10 years ago because of, you know, this approach, this technocratic approach that you had indicated. So that's it in a nutshell. But we ran a project to actually brief member states, your earlier point, on what this means and what the differences are.
Okay. Let's just hear one more question, and maybe they'll overlap somehow. Jonathan?
All right, I'll be brief. I mean, you discussed the securitization of health, and this is a trend that's been going on way before the pandemic, right? At least 911 and probably. But to what extent is your reading that this is also the responsibility of the health sector itself, when there's limited financing and there's an opportunity to piggyback military or this particular framing of health? It was maybe a bit opportunistic to join that, but it probably is part of the reason that we've gone down this track. I'm not sure that it's unique. How do we address this? I mean, you have money, and the EU will give us money to do 10 million euros of work in countries for health security. We understand that there may be broader issues that are deeper. Try to find ways to leverage that money so that it has proper usage than health security narrowly defined, but that's where the money is. So how do you view this, and what is the responsibility of the health sector putting us in this place in the first place?
Okay, and don't forget that question from the audience about what Canada can do to rebuild trust. Whoever wants to go first?
I can do trust.
Okay, do trust, and then Mark will do the rest.
All right. So we have to be realistic in terms of what Canada's position is going to be, because it's not just influenced by domestic, what's happening domestically, which is complex enough. It's also being influenced by relations with other powers, the United States particularly, but also the EU. So I would look at trust in terms of how does Canada develop its positions. So when it came to the pandemic, it didn't seem that Canada engaged with anybody else aside from the corporate sector. We read about the number of lobby efforts by pharmaceutical industry in trying to influence the position Canada was going to take on the TRIPS waiver. There were, I don't know, 30 or 40 with large drug companies. There was none, as far as I'm aware, with civil society. There was no discussion with civil society early on as to whether or not Canada should endorse CTAP, the COVID technology access pool. We never did. Canada seems to be moving slightly to a better position. So 2 months ago, there was a hybrid meeting to discuss the pandemic treaty. There were 100 people in Ottawa, and then there were another 30 or 40, I think, online. I'm not aware of any other country that's engaged in that kind of thing. Now, you can criticize the meeting, I have, but that was a first step. So transparency in developing positions involves meeting with people from various sectors. It means explaining what your positions are in clear terms. It means explaining what the evidence you used or to get to those positions is. And it means also, and this is where most countries fail, what were the discussions that went on? How did you interpret the evidence to come to your positions? Because evidence can be, as I said earlier around science, evidence can be interpreted in multiple ways. So you want people to trust your position. You need to have engaged with them. You need to have explained what your position is clearly, what evidence you used, or what statement or what positions you used. And then you have to explain what the discussions were internally that led you to those positions. And if Canada did those kinds of things, we'll still come up with some policies that I don't agree with, but at least you'll understand why they came up, why they were developed that way, why that was the ultimate result, and you'll know how to be able to influence it. And that's not just domestically, but other countries will also be able to understand Canada's position and know that, okay, you want to change something. This is how they did it, how Canada did it the last time. So this is where we need to focus our efforts if we're sending in ambassadors or civil servants to discuss with Canadian civil servants about what to do.
Great, and maybe to the group to think of this through the negotiation exercise, how you review the options and things when we go to that tomorrow. Keep that in mind. Is there an opportunity for us to use that as a way to gain that global trust and leadership? Maybe we go to our last reaction to the question, please.
Sure. And I'm not the best person to respond to this, certainly, but I can give an educated try. I think that, what we mean by the health sector means very different things in very different places, obviously. And so if you're looking at, kind of the global, the multilateral, I think how that is viewed, kind of what do we do to address the kind of surveillance and securitization agenda, is viewed very differently in different places and by different people. And part of it has to do with what is the aid framework and who determines where the aid budget is prioritized. And so there's another movement called global public investment. I don't know if many people have heard of it, but it's through lots of advocacy networks and civil society, NGOs, also involves some ministers, many countries around trying to build an aid framework that isn't through a charity model, but that is really based on everybody contributes according to ability, everybody draws according to need. And so, I think it ties in with the trust conversation too, but the more that we can move towards steps that show in low-income countries that this solidarity rhetoric that continues to be rhetoric actually might have some teeth. And it ties into the comment earlier about what do we do to actually bolster capacity of governments that don't have the ability to engage in all these conversations. And from civil society, how do we embed, places with resources, embed people in ministries of health, embed them in ministries of finance? When I was, in Sierra Leone and Liberia, we had 5 people that were embedded essentially in MOH to help with Global Fund, right? Because without that technical support and capacity, it's not that they don't have expertise, it's that they don't have resources spread across so many different areas to be able to engage in those negotiations and to put forward plans. There are countries that are missing out on tens and hundreds of millions of dollars because of what's called absorptive capacity, right? That is really a result of structural impoverishment of the public sector. So how do we, change aid frameworks over time as part of negotiations to build in capacity for public sectors to be able to have really legitimate power and legitimate opportunity to implement and to prove that they can deliver on so many of these agendas and treaties.
Okay, great. So we're going to wrap up thanking our panelists today, those who joined us online, our learners in our course, and those of you who joined us in person here for this session. And we will continue, obviously, with our course. I saw a comment made by one of the participants online, really reiterating, I think, what we could conclude out of this, that really the shift in how things are negotiated and the role of Global South and new emerging opportunities for different discussions in a way is a good thing and should help us achieve global health. And obviously capacity and being able to do that correctly is just as important, also emerged out of this discussion. Hence, you are in the right place. We are in the right direction. So we have a lot of work to do in Canada, obviously, and COVID was a good opportunity for us to learn. But this was a great reflection on the role that we could also play. So thank you those online and for joining, and for the rest of you, I think we're going to break for lunch now and then see you shortly after.
Can I just say something before we wrap up?
Mm-hmm.
Okay. Ilona talked about developing a multipolar world and the role of 6 middle power countries and that they're gaining in terms of negotiation. But I think we have to remember that what's going on internally in these countries and how is that going to reflect the positions that they take around global health. And aside from Brazil, which fortunately kicked out Bolsonaro, all of the other countries show evidence of losing some of their democratic values. So in India, Modi has been promoting Hindu nationalism. In Indonesia, there are rumors that Joko Widodo is going to try for a 3rd term, which he is not allowed to get. We've seen in Turkey the re-election of an authoritarian moving regime. South Africa I'm not sure about its democratic values, but certainly South Africa, from what I read, is riddled with corruption. The United States, which is still the major power, has slipped from a liberal democracy to a slightly illiberal democracy. At least it did in the ratings when Trump was in power. What's going to happen if Marine Le Pen wins the next French election? So we have to be aware that, yes, power is shifting internationally, but power is also shifting domestically, and that's going to have an effect on what countries do or don't do.
Okay, thank you.